Let's talk distal radius fractures. So if you are a PA new to orthopedics, this will be a great introduction. If you are an experienced PA, it'll be a nice little review. I'm an orthopedic surgeon that took more than 200 call shifts last year, so I've seen a few distal radius fractures. So let's get started. Does this x-ray, does this fracture need surgery? Does this wrist need surgery? Does this fracture need surgery? Well, it's not always so straightforward. By the end of this talk, I'd like you to have some idea of the recommendations that we have, whether or not these fractures need surgery. So here are my 4 goals for this talk. Number 1, distal radius fractures. Yes, we call it one name, but it actually has 2 flavors, and they act like 2 completely different animals, kind of like a king snake and a coral snake. They look almost exactly the same, but one is poisonous and one is safe. 2, I want to go through my foolproof reading x-rays system so you don't miss any problems on wrist x-rays and nobody gets sued. Number 3, one mold for distal radius fractures does not fit all distal radius fractures. I'm going to show you the cases in which you have to do a different type of mold. And finally, when do we consider surgery? So, again, 2 different flavors of distal radius fractures. Here's the first one. And here is the second one.
Into cap, holds up ceiling to, oh! Down goes, walks in a big one.
All right, so the second one is much more dangerous than the first one. So the first one, fragility fracture in elderly patients, the type of fractures we see all the time. The second animal, the young patient with a good bone, high energy fracture. Well, this is a whole nother beast. And if you take away anything from this talk, if you stop watching this video after the next 2 minutes, I want you to realize that when one of these young patients comes in after a car accident, big injury, getting assaulted, any of these higher energy mechanisms, you have to check a whole nother set of criteria. First of which is checking the soft tissues. Any kind of high energy trauma, soft tissue, soft tissue, soft tissue. In the case of distal radius fractures, it's number 1, the skin, is this an open fracture? Compartment syndrome comes into play. The median nerve travels right over where that distal radius fractures, and even the ulnar nerve is in play. The other important structures are the flexor tendons. So the flexor tendons right under where those fractures lie. So check the thumb flexors especially, and all the finger flexors. So high energy animal, that's the dangerous animal. Soft tissue, soft tissue, soft tissue. Not to mention all the other traumatic injuries that person might have had. So you want to do a full, complete trauma workup. Young patient, good bone, high energy. Think of it like that dangerous poisonous snake. So the fragility fractures are the ones that we see all the time. Maybe you treat them more routinely. And the more young patients you want to treat with some extra attention and caution. All right, well, let's go through some normal x-rays. Before you go to the abnormal, here's my system for looking at normal wrist x-rays. And when you see any fracture, especially if you're new, I want you to start by ignoring the fracture. So in this case, you're going to ignore the radius and you're going to look at some other things. And we're going to start with the carpal bones. And I know everyone says, learn all the carpal bones. Well, I'm here to tell you, don't learn them all right now. Just learn 3. And the 3 you need to learn are the capitate, which is here, the lunate, and the scaphoid. And you need to check not only the bones, but also the space between the bones. So the space between the capitate and the lunate here, the space between the scaphoid and the lunate, which is called the scapholunate injury. Now, remembering the scaphoid, it's a kind of boat-shaped injury. The lunate, it's got its name because of its shape on the lateral, which is shaped like a moon. So on the lateral, here is the lunate. I'll trace it here for you. Looks something like that. So that is the lunate. Now the capitate, one way to remember is that the capital bone of the wrist is the bone that's in the center of the wrist. So I learned in 3rd grade that Washington, D.C. was picked as a capital of the original 13 colonies because it was in the center of the 13 colonies. So the capital bone of the wrist, or the capitate, is in the center of the wrist. On the lateral view, capitate is also very important. I'm going to draw the general outline of the capitate, which looks something like this. And that's important because on every wrist x-ray, you should make sure the capitate and the lunate and the distal radius are all lined up. If not, you have what's called a lunate dislocation if the lunate is dislocated, Or if the capitate dislocates, we have what's called a perilunate dislocation. More details in later talk. So first thing you do is look at the carpal bones, the 3 key carpal bones, and then we're going to move on. The next bone you want to look at is the ulna. We have the ulnar styloid here, that little nipple. We have the ulnar head. The ulnar head should be about the same height as the ulnar corner of the radius. And finally, we'll go to the radius. And the first thing we usually think about is the angles. So the first angle is called the radial inclination. So if you take a line that's perpendicular to the axis of the radius, which looks something like this, the axis of the radius is here. You draw another line that's going to connect the radial styloid tip down to the ulnar corner. Well, that's going to make an angle, which on average is about 23 degrees, which is Michael Jordan's number. Good way to remember that. Now on the lateral, there's also an angle to remember. Now, if you take this corner of the radius, which is called the teardrop, and the dorsal corner of the distal radius is actually a tilt. It's tilted volarly. And so again, if you make a line along perpendicular to the axis of the radius here, if you draw a line from tip to tip, that makes an angle too, which is on average going to be about 11 degrees. So those are the 2 angles that you need to remember. And some additional details to make you a real superstar at reading these. Number 1, the radial styloid here. We have these 2 fossas. If you notice, there's a little extra line here. There's a little extra curvature here and a curvature here. And this curvature here is a little fossa in which the lunate sits. So we call this the lunate fossa. And this little fossa here is called the scaphoid fossa. So if you can describe fractures, it might exit out the scaphoid fossa or the lunate fossa. And the final little home on the distal radius is this sigmoid notch. It's a little area in which the ulna articulates with the distal radius, or what we call the distal radial ulnar joint. All right, so that's the normal wrist x-ray. Any x-ray you get, you should go through those steps and you'll get pretty quick, and we'll go through those with all of our fractures today. All right, so let's go through an abnormal x-ray. So here's an AP of a skeletally mature wrist and a lateral. We're gonna start with the carpal bone. So here's the capitate, here's the scaphoid, here's the lunate. The scapholunate interval looks normal and the other carpal bones look well reduced. On the lateral view, let's find the capitate, which is something like this. The lunate is here. We got the capitate, the lunate, and the distal radius. And all those line up, so there is no lunate or perilunate dislocation. First step done. Next, we're gonna look at the ulna. So here we have an ulnar styloid fracture. The height of the ulna is about even with the distal radius. There is no significant radial shortening. And finally, we're going to go to the fracture. So here's our fracture here. Here's our extra-articular distal radius fracture at the metaphysis. On the lateral view, here's our extra-articular distal radius. On the AP view, we have lost most of our radial inclination. If I had to guess, it's probably, 10 degrees. On the lateral, we have lost all of our volar tilt. So the distal radius should be tilted volarly. It should be this line, but it's actually tilted the opposite way. So it's dorsal tilt or dorsal angulation, and it's tilted maybe 20 degrees dorsal. How we describe this is a distal radius fracture, extra-articular with dorsal angulation, and the eponymous name for that is a Colles fracture. All right, so you see this patient, you do a soft tissue examination, do a physical examination. Now the next step, we have to reduce it and stabilize it. So typically what people do is hang them from some finger traps, or if you have an assistant, and the assistant will hold the arm and you hang some weights for it. We would use saline bottles we found in the ER to hang weights through a stockinette. So hanging it will bring the arm out to length. And I think this is a very important key. When you put the splint material on, you want to make sure this distal part of the splint does not cover this distal palmar crease. You do not want to cover that distal palmar crease with what palm readers call the heart line. And the reason is, if you cover that, the patient cannot flex the MCP joints. And if you're doing this even for a week or two, it's very hard to get the fist back. So one thing you can really help early on is putting that splint material proximal to that distal palmar crease so the patient can flex the MCP joint. If you do have extra splint material, which happens, make it long on the dorsal side here. It doesn't matter if there's a bunch of split material on the back of the hand because it doesn't block any digit extension. So make sure that the splint is short on the volar side and make it long on the dorsal side, if anything. And here's a picture of a standard splint, a standard distal radius splint, 3-point mold, which we'll review later. But here's one mold, here's 1 point, and here's 1 point. So here's that same fracture that's reduced. Let's look at the mold on the lateral view here. Now, first of all, I might have made this a little bit shorter to allow some NCP flexion. But here's a mold. 1, 2, 3, nicely done mold. We got this nice sort of banana shaped here. We have restored our volar tilt. We have reduced the fracture well in that plane. We have restored most, if not all, of our radial inclinations. So very well done reduction. But there are cases in which that standard splint does not work. So let's look at this x-ray. Here's an AP and lateral of a skeleton mature wrist. Let's go through the carpal bones. Here's our capitate. Here's our scaphoid. No fractures, but it looks a little bit funny. Here's the lunate. And already you can see there's a widening of the scapholunate interval, so scapholunate widening on that view. On the lateral view, we have the capitate, we have the lunate, and the radius, so no lunate or perilunate dislocations. The ulna shows no fractures, and there is a significant radial shortening. You can see the ulnar head is much more distal than the articular surface of the distal radius. And finally, let's get to the fracture. So here's our fracture. It is an extra-articular fracture of the distal radius and the metaphysis. On the lateral view, we also have an extra-articular fracture. In this case, we are displaced volarly. So it's the opposite of the standard dorsally displaced radius fracture. The eponymous name for this is a Smith's fracture. So if you would go do your standard distal radius 3-point mold with one here, and one here, and the banana is sort of shaped like this, are you making this patient better? Well, no, you are not making this patient better. If anything, you're making this patient worse because you're pushing the fracture back to where it displaced in the first place. So what you should do, say you hang the patient from finger traps and it lines up just perfectly, and the fracture looks something like this. What you need to do is the opposite 3-point mold. So the first point is going to go this way. We're going to push this distal piece dorsally. The second mold at the fracture site this way, and the third point this way. So we have the opposite mold. So the banana of the splint is going to go the opposite way like this. So that's going to help maintain that beautiful reduction that you have just done. Let's take another example. Here is an AP lateral of a skeleton mature wrist showing, number 1, let's go through the carpal bones. Capitate, scaphoid, lunate. No scapholunate widening. On the lateral view, here's the capitate, here's the lunate, and here's the distal radius, so no significant lunate dislocation or perilunate dislocation. The ulna shows no fractures. There is some slight radial shortening. And here's our fracture. On this view, it appears an extra-articular fracture. We have lost pretty much all of our radial inclination. On this lateral view is where the real story shows itself. We have this coronal plane fracture. It's not a typical plane fracture. It's a coronal plane. We'll call a shear fracture. And this is a very unstable fracture. It does also have an eponym that's very useful called Barton's fracture. And since this is the volar side, we call it a volar Barton's. If this fractured off the dorsal side, that dorsal shear fracture, we call it a dorsal Barton's. But this is a volar Barton's fracture that is displaced. So you hang this on finger traps, and how are you going to put a mold on this? Well, once again, what if we do our standard 3-point mold? One there, one there, one there. Is that helping us at all? Well, once again, no and not. That's actually making it worse. We're actually pushing more pressure down on this bone and probably making the fracture worse. So what you should try to do instead is almost the opposite. And so you would push the first mold here, the next point here, and the next point here. Now this can be challenging in itself because since there's no fracture on the dorsal cortex, it's hard to get a 3-point mold. So practically speaking, when you see a volar Barton's, you just want to extend the wrist a little bit, provide some ligamentotaxis on this volar structures of the distal radius, and hope that you can hold some stability. But this is such an unstable fracture pattern. In most circumstances, this is going to need surgery. All right, next example, AP lateral of a skeletally mature wrist. Here's a capitate. Here's a scaphoid. Here's a lunate. The scapholunate interval is not widened. On the lateral view, here is a capitate. Here's the lunate. And here's the radius. So no lunate dislocations or perilunate dislocations. The ulna is not fractured. The DRUJ is reduced. There's no significant radial shortening. And here is our fracture. So this is our first intra-articular fracture on the AP plane that we're seeing. And it involves just the radial styloid. There is no loss of radial inclination. There's really no loss of volar tilt. Now, how are you going to reduce this and put a mold on this? If you do our standard distal radius mold, one there, is this doing anything? Well, at least you're not hurting it, but actually not really helping anything. But really the deforming force is in another plane. So in this fracture, there's a muscle called the brachioradialis. It's going to pull this distal radius this way. So that is what you have to fight against when you're making this mold. So when you're making this mold, your first point of mold should be more this way, more in the coronal plane. So you're kind of going more ulnarly. The second point is going to be here, going from ulna to radius, and the third one down here. So if anything, the mold's going to be kind of in this banana shape. Now, in order to do that, you have to put something around the thumb, or what we call a thumb spica splint. Again, practically speaking, it can be hard to make that mold. This guy's doing a pretty good job on this picture. Here's 0.1, 0.2, 0.3, but practically speaking, all you're really trying to do is pull length on the radial side of this wrist to pull some ligament metatarsus to fight this brachioradialis pull here. So if I can draw this on this picture, it's making a thumb spica splint and just pulling on this thumb, pulling the wrist into a little bit of ulnar deviation. That's probably the most stable splint you're going to get for this fracture. All right, this should be the final example. We have an AP lateral of the skeletally mature wrist. Let's go through the carpal bones. Capitate, scaphoid, lunate, no fractures. Scapholunate interval looks normal. On the lateral view, here's the capitate, here's the lunate, here's the radius. So no lunate or perilunate dislocations. There's no ulnar fracture. And let's look at the fracture. So here's our fracture. There's a fracture line here. Here's the lunate fossa, articular surface, and here's the scaphoid fossa. And there is a clear step off here. On the lateral view, you can see the step off here. Another unusual fracture pattern. And what's happening is this lunate has acted like a hammer to punch down onto this articular surface. We actually call this a die punch fracture. Now, we're going to reduce this and splint this. Does doing that 3-point mold help? It's like a broken record. 1, 2, 3. Well, no, it's not really doing anything for us at all. So for these fractures, all you can really hope to do is just pull length. You're just going to pull length this way, splint it in almost a neutral position, and hope you can pull it out to length. But again, if this were a young patient, that kind of younger high energy patient, this probably just needs surgery in order to reduce that joint. All right, so we're past the reduction phase, patient stabilized, maybe going home, maybe seeing you in your office. How do we decide who needs surgery? So again, we have two flavors to this. We have grandma and we have the young guy. So grandma and Happy Gilmore in this scenario. We have to divide them into two separate buckets. Now, we're going to base this off of the most recent clinical guidelines from the Academy and the American Society of Hand Surgeons. Any patient over 65, we cannot find in any meta-analysis that surgery makes any functional difference after 12 months. So early on, you might get some benefits, but at 12 months, whether or not you had surgery or not have surgery, everyone did about the same. Even if they have a significant malunion and a significant deformity, all the analyses show that surgery doesn't really provide any functional benefit. That's for a couple reasons. Number one, their baseline function is pretty low. They're not lifting manhole covers or playing football or doing any high-level things, so their demands are much lower. And also their bone quality is poor. So the surgery itself may not be as successful. It's like the analogy is trying to pick up sand with a fork. So you're trying to hold screws into this very soft bone. You can even see if you can even get the bone reduced, the plates and screws just cannot hold that reduction. So for those two reasons, I think surgery logically makes sense that it'd be less useful in this patient population. So according to the current guidelines, past the age of 65, surgery really doesn't have a benefit. Now there are scenarios in which you should do surgery, in even this age group, because not every patient is the same. We're not robots, we're not just AI creatures here. So if you have a patient that's very active, they play the piano, they play pickleball, they want to get back to lifting weights and doing yoga as soon as possible, well, surgery can definitely benefit that person because they're not living in a cast or a splint for 6 weeks. You can also have other scenarios like tendon injuries and open fractures and things. But by and large, the age 65 plus, if they can tolerate a crooked wrist and they don't really have any high demands for that wrist, a lot of people do really well in papers and in my own practice. People do well even with a wrist that looks obviously deformed. So that's the 65 and over category. Let's move on to the second flavor, the younger high energy patient. Well, that's where all our discussions about the joint and the x-rays really come into play. So let's talk about the soft tissue indications for surgery. Well, like we said, it's a soft tissue evaluation after these high energy injuries, and a lot of them have acute carpal tunnel syndrome. So the fracture fragments will push on that median nerve, and that is an indication to reduce the fracture, release the carpal tunnel very acutely, as in within the first 24 to 48 hours. I did have a scenario in which a 20-something-year-old was in a high-speed motor vehicle accident, and this was treated like a standard fragility fracture. The patient was sent home, had delay of care, thankfully ended up okay, but that patient was not treated correctly because we treated that young, high-energy patient like the same way we do our 80-year-old fragility fractures. The second soft tissue indication would be open fractures. So it seems to be the case in data and in real life that any significant open fractures, especially if it's a significant grade injury, should be stabilized and the soft tissue addressed at the same time. What about the bony indication? So this is based on the most recent clinical practice guidelines. When the radius is shortened any significant amount, and that would be defined by 3 millimeters or more, we generally want to reduce that and fixate that in these young patients to prevent post-traumatic arthritis. If there's any dorsal tilt, so we talked about the most common deformity is going to be that dorsal tilt, the dorsal angulation. If it's more than 10 degrees, which means if the normal volar tilt is 11 degrees, if it fractures and tilts 10 degrees the opposite way, well, now we're talking a 20-degree difference. So that is an indication for surgery. And any intra-articular step off. So that includes the radial styloid fractures, the Barton's fractures, the volar dorsal Barton's, die punch fractures, anything that involves the joint surface should be reduced to help prevent post-traumatic arthritis. So those are our two flavors in a nutshell, and I'm going to go quickly through the surgical options. Essentially, there are 5. The last 2 are really falling out of favor, but option 1 is volar locked plating. That is the mainstay. That's the workhorse of distal radius fractures now in modern days. It's usually a FCR approach. As long as you keep these distal screws short of the dorsal surface, you avoid any extensor tendon irritation. Second option is fragment-specific plating. So all these little plates have their specific roles. So a radial styloid, the radial column has a specific plate. The ulnar corner or the intermediate column has a special plate. The scaphoid fossa has a plate. There's a dorsal plate. Now, dorsal plates, the main problem with dorsal plates is that it irritates the extensor tendons and usually results in needs for plate removals. Here is a dorsal wrist spanning plate. This is not a fusion plate. It is actually acting like an external fixator. So patients with that poor quality bone in which the screws aren't likely to hold a great reduction, this acts just to neutralize the fracture deforming forces. Now, a lot of people put this plate on with or without pins or even a distal radius volar locking plate, but the plate is there as a 2-stage surgery. So this is a 2-stage surgery. The first one is to hold it out to length, neutralize the forces across the distal radius until that heals, and there's a second surgery down the line, 3 months, 6 months, however many months down the line, you take that plate out, and the patients have to understand that. Next one, something that is falling more and more out of favor, but you can do percutaneous pinnings in this. Closed reductions, percutaneous pinnings, obviously less morbid from the soft tissues, from the open approach, but you have pins coming out of the patients that have to be removed. There's chance of pin site infections, and patients usually still have to be immobilized in a cast or a splint. And finally, external fixators. Again, in my practice, not really used that much, and from reports of hand surgery and other even videos that people report their results on this, patients do not tolerate this very well. that don't enjoy having this. It does have a role in certain situations for sort of temporizing fixation, but these by and large have been replaced by the dorsal wrist spanning plates that go underneath the skin. Well, thanks for watching. If you've gotten this far, you have opened a super secret opportunity. As this channel grows, I'm always looking for PAs looking to help grow the channel. So if you want to participate and help provide me some feedback, some critiques, maybe learn something, maybe you can get involved in the channel, please send me an email, willkangaroo@gmail.com. And thanks for watching.